Good morning, good afternoon, good evening, wherever you are. Thank you so much for coming on to another live stream for intensivecarehotline.com and intensivecareathome.com. I'm your host, Patrik Hutzel, founder and managing director of Intensive Care Hotline and intensivecareathome.com. I'm here to answer your questions live. Answering your questions for families of critically ill patients in intensive care, but also for intensive care at home. Before I go into the questions, I can see there's questions here already. Before I go into today's questions, what makes me qualified to answer questions for families in intensive care? I am a critical care nurse, having worked in critical care for nearly 25 years in 3 different countries, where I also worked as a nurse unit manager for over 5 years. I have been consulting and advocating for families in intensive care all over the world since 2013 as part of intensivecarehotline.com. I can say without the slightest hint of exaggeration that we have saved lives with our consulting and advocacy, and you can look that up on our testimonial section. And you can look it up on our podcast section, right? And we have saved many lives, right? And we have also helped many families in intensive care to get end of life situations on their terms, right? And the work that we've done really, I believe, speaks volumes. The other thing that obviously I'm doing is with intensive care at home. We are sending intensive care nurses into the home for predominantly long-term ventilated adults and children with tracheostomy. We do that in Australia at the moment, in all major capital cities, as well as in regional and rural areas. And we also provide NDIS specialist support coordination, level 2 and level 3 NDIS support coordination. And we have been, again, in business since 2013. We've been providing hundreds of thousands of hours of intensive care at home nursing. And, we've been very successful there as well, freeing up ICU beds, improving the quality of life for patients and for families, and saving the health system half of the cost of an ICU bed and freeing up ICU beds. So again, it's a win-win situation. If you need intensive care at home, or if you're curious about intensive care at home, go to intensivecarehome.com. Now, before I answer some questions here, I just quickly need to respond to a text that is urgent. That is what happens when you're running a business. I just quickly need to respond to a text, and that is urgent. It just got to give me a second. I can see your questions and I will get to them in 1 second. Just give me 1 second. Okay, so now, Leo, you welcome back to this show. I know you've been a regular here. Let's go to your question. So, Leo, you're saying, my father has been in ICU since November on a ventilator and struggling with secretion management. He's very weak. How can I help him improve secretion management and regain strength to go home? Okay, great. Now, I do remember you're saying your dad is on a ventilator. I would imagine he's got a tracheostomy. I think that was the case with your dad. Okay, secretion management. The first thing that you probably need to look at is what size tracheostomy does he have, right? The next thing you need to look at is he getting regular nebulizers? And regular nebulizers could be The most important one would be saline nebulizers. The other important one would be potentially Ventolin or Atrovent nebulizers. Is he getting nebulizers at all? The next thing is, does he have an inner cannula? Right? Some tracheostomy patients have an inner cannula, others don't. Patients that have an inner cannula usually have plenty of secretions, right? And that's, it's one of the determining factors whether you put an inner cannula in or not, whether patients have lots of secretions or not. So, so those are things to be looking for there. The other thing that needs to happen with managing secretion is mobilization. Now, when you mobilize a patient with a tracheostomy and a ventilator, you may not be able to mobilize secretions. As soon as you mobilize a patient, get them out of bed, sit them up, do physical therapy, all of a sudden secretions will come up. Right? Common sense. Common sense, which is not all that common. Right? So I hope that answers your question with secretion management. Other things that can help with secretion management sometimes are, changing position left to right, which ties right in with mobilization. Some of it will also come down to head down sometimes, to drain secretions, let gravity work, right? Other things that can help is cough assist machine. What a cough assist will do is, for patients that can't cough, well, that's another thing. Is he getting coughing exercises? Is somebody helping him with that, right? So if he can't cough and no one is doing coughing exercises with him, right, can he have a cough assist? The cough assist is basically helping ventilated and tracheostomy patients to cough, but it can also help patients that are not having a tracheostomy to cough, even on BiPAP or on CPAP. Basically, what a cough assist is doing, it's giving patients a PEEP of 5, 10 for 3, 4 breaths, and then a negative PEEP, and that makes them cough, right? So, Leo, I hope that answers your question with if he's struggling with secretion management. Next, your next question. He had a cardiac arrest resulting in a anoxic brain injury, currently in a vegetative state. He has a tracheostomy and requires dialysis. Vegetative state, okay. So, and then thank you for your guidance. Since transferring to this ICU's neurological state has declined to a vegetative state with loss of tracking, leg movement, and left arm and mobility. Leo, why do you think his neurological condition has deteriorated? Why do you think that is? I do remember he went to LTAC and then bounced back into ICU. I remember that. You've been here before. Right. So why did his neurological condition change? What has changed? Has there been another neurological insult, another neurological event? Right. Would be good to get an answer here. Why would his neurological condition have changed? Okay. Then, so if you could answer me there, Leo, that would be good. Why has his neurological condition deteriorated? What was the reason for that? Now, next question is from Dare56. Oh, no, there's no question. It's just hi. Well, hi, Dare56. Nice to see you again. Leo, yes, he gets breathing treatments throughout the day and can dogs, and he has an inner cannula. Aside from the septic shock, there has been no other thing that could have affected him. Have you asked them? Have you asked them why his neurological condition has changed? Has he had a follow-up CT scan, follow-up MRI scan? Has he had that? Right? Has he had a neurological consult? Those are the things that would be important here. You know, and coming back one more time to the issues with secretion management, he needs to get out of bed. He needs to get out of bed, get mobilization, get physical therapy. That's half of the battle. Okay, so then day 56. We had talked in another life about my mother. She got a cardiac arrest inside hospital in Bielefeld, Germany. And after 1.5 months in coma, and then Richard said the last time we talked, my mother, okay, you would need to continue the conversation. Yeah, I do remember talking to you here. So while I'm waiting for Leo, and ICU refuses CT scan or MRI. Why is that, Leo? Why is that? Why are they refusing MRI scan? Sorry, I'll post the StreamYard link here. If you wanted to come onto the call here, you're welcome to join me live on the call. I've put the StreamYard link here. You're welcome to join me on the call live here. And you can talk to me directly, whoever wants that. I can see there's quite a few people here. Whoever clicks on that link first and wants to join me here and talk to me live is welcome to do so. In the meantime, while I'm waiting for Dare 56 and Leo to give me more information, I will get to some questions that have come in during the week. I'll just have a look at my emails, and I will. Okay, Dare 56 says, the day that they removed her from ICU, she gained some consciousness. I was telling her jokes, and she laughed, and she began to respond to questions about water and music with this, and no, moving her head and by speech. Okay, what's your challenge, Dare 56? What are your challenges? What do you need help with? Whilst I need some context, I also need the questions that you have. What questions do you have? Okay, in the meantime, I'm just reading out some comments from a reader. My mom self-extubated herself after 1 of 4 intubations because when mom had a code blue, due to iatrogenic malfeasance, manipulated malpractices induced personal injuries. The respiratory technicians did not place a tooth guard on her breathing tube. No one would tell me how long she was not able to get oxygen to her brain. The ICU physicians covered it up and downplayed it. Well, this is a comment that I had from Helene on one of the videos. And well, here's the thing. What I keep saying over and over again, you need to take responsibility from day one. It's one thing to go back and say, well, they didn't tell me and didn't do this and didn't do that. It's your responsibility to take action and do research from day one. It's not good enough. It's okay to lay blame, right? But it's not okay to not take responsibility to begin with and do the research that's needed from day one. You now know that you are in a once-in-a-lifetime situation that you can't afford to get wrong. I mean, that's becoming abundantly clear by all the questions we're getting here. You cannot afford to get this situation wrong. And yes, patients in ICU do pull out their breathing tube at time if you're not managing them correctly. It's one of the risks in ICU, but it also comes down to taking responsibility. Okay, Dare 56, you're saying now they're sending her to a Pflegeheim or Altenheim, which I know what it is. It's basically a nursing home. So is this best for my mother, or is a rehabilitation center better because they're sending us to a nursing home and not a rehabilitation center? Okay, so Dare 56, what's the condition of your mom? Does she have a brain injury? Does she have a tracheostomy? Does she have a ventilator? Can't she go home with hospital in the home, which is called a Sozialstation in Germany? Can't she do that? Right? But what's her underlying condition? Only then can I really point you in the right direction. If you tell me what is her underlying condition and does she have a ventilator and a tracheostomy? Okay, Leo, you are saying neurology refuses further intervention, citing no hope for recovery, without justifying their decision or conducting imaging. Okay. The neurology only spent less than 5 minutes with him during their single consultation. Okay. So, Leo, what you need to do here is, have you made a complaint to hospital executive? I think I talked to you about this before, that you need to escalate this to hospital executive, right? And we have helped so many families making complaints to hospital, and making complaints successfully, just by helping them craft an email, getting all the facts together, looking at medical records. You know, I mean, that's negligent. You are describing negligent behavior here to me, Leo, and you need to escalate this to hospital executive. You know, it's negligent, not that neurology doesn't want to intervene here and doesn't want to treat, right? Doesn't want to consult. You know, that's part of our consulting and advocacy, to write letters for emails, write letters or emails for clients, you know, and get outcomes, get results, see behavioral changes. You know, we actually get outcomes for families in intensive care. We make sure that their loved ones get best care and treatment. Have a look at our testimonial section. So that is what you need to do there, Leo. Escalate it. You cannot solve a problem at the level that it was created at. The level that the problem is created at is in ICU and with neurology. If you can't get anywhere, you need to take that out of the environment. And taking it out of the environment is by escalating it to hospital executive. And that is your next step here. Okay, that is your next step here. And again, we can help you with that. You would need to reach out to me separately. Just call me on one of the numbers on the top of our website at intensivecarehotline.com, or book a call with me, you know, and I can help you with writing a letter, you know, or an email that gets outcomes. Okay, Dare 56. She has removed the tracheostomy. She has removed everything, and she's on her own. She's shaking her hands and her head. She's away from tracheostomy and ventilator. Okay, so if that is the case, so does she have a brain injury? Has she been diagnosed with a brain injury? But the question here is really this, Dare 56. Is the nursing home the best thing, Pflegeheim or Altenheim, or is she better off at home with hospital in the home, or, you know, again, what's called a Sozialstation in Germany, right? You know what I'm talking about. You know, she has a hypoxic brain injury. Okay. So what stops you from taking her home with 24-hour nursing care at home? What stops you from doing that? Have you explored that option, or do you see the Pflegeheim, the nursing home, as the only option? And also, she probably should go to rehab, because that's the only way she can get better. Have you spoken to the neurologist? You know, have you spoken to the neurologist, Dare 56? What are they recommending? You know, the reality is, she won't improve, or very unlikely she will improve without, rehabilitation. In a nursing home, unfortunately, she will just wither away. Right? That's the unfortunate reality. I would talk to neurology, and I would also ask them, why not rehab? I haven't explored this option because I have 3 brothers that are 16, 17 years old, and they're giving exams and teachers are getting every day in house. Sure. Yeah. No, I understand. It's not doable for everyone. I get that. Right? I get that. But it's obviously something you may want to consider as an option too. But I would work with facts, right? And the facts are, you know, can she go to rehab? What's neurology saying? Can you do rehab at home? You need to talk to the neurologist, Dare 56. You absolutely do need to talk to the neurologist here. Well, rehab might be better. I can't remember also how old is your mom. Not that it really matters, not that age really matters, you know, whether she should go to rehab or not. But talk to the neurologist. Talk to a rehabilitation physician, to a rehabilitation specialist, you know. One thing is for sure, if you're not going to rehab, you never know whether she'll improve or not. You'll never find out. You'll only find out if you do take her to rehab. You know, other than that, you will only ever be guessing whether she would have improved or not, right? So keep that in mind. Keep that in mind. Okay, so I understand from the hospital neurologists were telling me that she will be in a vegetative state, and now I have a communication with her. Yeah, absolutely. Absolutely. You got to look at what's happening, not what people are saying. Watch what people do, not what they say. Improvement is rehabilitation center. Well, let's put it that way. There's no guarantee for that, but your chances will be much better in a rehabilitation center. They will be much better. Okay. Leo, you're asking how long after a brain injury does the window of opportunity for recovery typically close? It's hard to say. It's not a one size fits all. The sooner the better. I argue that every day you're not rehabilitating is a waste of time. As soon as someone is stable enough to do physical therapy, to do breathing exercises, is able to be mobilized. If you're not doing that every day, is a waste of time, right? And the reality is, another analogy here is, okay, anyone who has kids, right? How long do you give your child to walk? If they're not walking after 12 months, if they're not walking after 15 months, if they're not walking after 18 months, do you give up? Will you say, my child will never walk? Well, it's the same with recovery and rehabilitation. Will you give up? Will you say, oh, well, my family member is never going to improve? I would approach it with that mindset. I would approach it with that mindset. Every day you're not rehabilitating is a waste of precious time. Every day you're not trying is a waste of precious time. Okay, Dare 56. Also, they were telling me that the possibilities were near zero, and now I have communication. Yeah, sure. I did a YouTube live yesterday, Dare 56, how to, hang on, I'll give you the exact title. Just give me 1 second. I'll give you the exact title of my YouTube live yesterday. I can't even remember the exact title, but I'll give you the exact title, which was how to handle doom and gloom scenarios from ICU teams when your loved one is in ICU. Well, they've given you the doom and gloom. So I encourage you to watch the video from yesterday, how to handle doom and gloom. Again, watch what they do and what people do, not what they say. Now you have communication and your mom supposedly has a brain injury. That comes back to your question, Leo, as well. How long do you wait? You don't wait. You just get things going. Dare 56 from hospital, they are telling me that they're surprised about her improvement. Yeah, that's good. That's a good surprise, a nice surprise, isn't it? Leo asking, are there ways to mobilize somebody on a sandbed? Yes, absolutely. So the ways to doesn't matter whether they're on a sandbed, on an air mattress, on a normal mattress. get them out of bed to a chair. It's no more complicated than that. It is no more complicated than that. How do you get them over to a chair? You can slide them on a tilt chair. You slide them over and then tilt the chair, or you use a hoist or a lifting machine. It's bloody hard work. I've got nothing to offer but hard work here, but it's doable. I can't believe, and I'm probably an old-fashioned nurse, having done my training in the 1990s, where we were mobilizing people left, right, and center, right? Not mobilizing, I believe, is negligence. It's nursing and medical negligence. So to answer your question, Leo, how are there ways to mobilize somebody on a sandbed? Yes, get them out of bed, sit them on the edge of the bed, get them in a chair, right? It's all doable. If they're not doing it, they're lazy and complacent. I've got nothing to add here. The only way you can't mobilize someone is if they're hemodynamically unstable, right? Or if they have fractures or waiting for surgery, that sort of thing. Other than that, nothing stopping a patient from getting mobilized. You're welcome, Dare 56. Okay, so now, if anyone wants to join me live here and wants to talk to me directly, here is the StreamYard link again. If no one has any other questions, I will just go to the emails that have come in during the week. Now, just give me 1 second. Okay, question from Christine, who says, hi, Patrick. My dad may have to be intubated in ICU and he's 2 hours away. Well, that's a concern, but it also comes back to, you know, what I keep saying over and over again. The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Well, the first thing is, why does your dad need to be intubated? Why is he in ICU, or maybe he's just in the emergency room? Why is he there, right? Why are they proposing to intubate him, right? Do you have access to the medical records? Can you and I talk to the doctor and find out what's happening? You know, my job is to make sure you will make informed decisions. You have peace of mind, control, power, and influence. That is my job here, right? So my job is to guide you. Are you the medical power of attorney? You know, are you the medical power of attorney for your dad? You know, once again, you are in a once-in-a-lifetime situation that you can't afford to get wrong. You know, intubating your dad or not intubating him is a big deal. Big deal. What do the chest x-rays show? What do arterial blood gases show? What's his conscious level? Have they tried BiPAP or CPAP? Have they tried high-flow nasal prongs, right? Have they tried nebulizers, right? Have they potentially done a deep suction? Can they do a deep suction if there's sputum accumulation on the chest, right? Why does he need intubation? Does he have a pneumothorax? Would a chest tube potentially help? Right? So I hope that helps and answers your question there, Christine. Next question from Nicola. Hi, Patrick. My son was ventilated while in ICU. Transferred to a specialty hospital to be weaned off. He was successful, although his awareness was not where they felt it would improve. Then he was transferred to a rehabilitation facility / nursing home, where he and my concerns were discounted and ignored. He has been back hospitalized 4 times out of 3 months. due to lack of knowledge on behalf of the nursing facility staff, non-existent physicians, nurses and RTs. Now, after his last hospital stay in ICU, he was transferred back to a specialty hospital. He has to be admitted there for 1 month and 3 days. Now the social worker keeps calling me for the purpose of, have I chosen a nursing facility for my son to be transferred after insurance stopped paying for his care in his current setting? I'm frustrated because the state of Illinois seemed to not care about a patient who has a traumatic brain injury. That's very sad, Nicola, to hear about your son's situation. Now, question here is, or another thing here is, like I say over and over again, don't go to LTAC, which is what's happened here. Now her son is back in ICU. Now, my advice here, Christine, is, Nicola, is talk to the health insurance and find out what you're entitled to. You'd be surprised. We had a client recently who was sort of faced with a similar situation where he was told his mom is running out of ICU insurance entitlements and, she needs to go to an LTAC. I said to the client, well, get it from the horse's mouth, talk to the health insurance. And he spoke to the health insurance and the health insurance said, no, it's all within green lights. His mom still had ICU entitlements and they weaned her off the ventilator in ICU. Now, my question here is, Nicola, why can't he be weaned off the ventilator while he's in ICU there? What's stopping him? Are you asking the right clinical questions? Do you have access to the medical records? If he can be weaned off the ventilator, him going to rehab will be so much easier. You got to ask those questions. Where is he? Can they, in the ICU, can they wean him off the ventilator? Is he getting mobilized? Back to the question we asked before. Is he getting mobilized? Is he getting the right breathing treatments? Is someone having a plan to wean him off the ventilator? Right? What medications is he on? What are his blood results showing? Is he getting mobilized? Is someone doing breathing and coughing exercises with him? Is that a possibility? I don't know. You haven't shared enough with me. Is a nursing facility the right next step for him? Do you want to take him home? Have you considered that? But the bottom line here is, every time patients leave ICU and they're going to LTACs or rehabilitation facilities on ventilation with tracheostomy, it's doomed to fail. Yesterday on this YouTube live, there was also someone who said, well, their loved one bounced back from LTAC to ICU within 24, 48 hours. I hear these stories every day and have been hearing it for many years. So guys, you need to do your research from day one. Please don't come to me and say, oh, my loved one went to LTAC and now it's all bad. Well, I've been warning about this for the last 10 years. Once again, take responsibility for what's happening and take responsibility from day one, right? Take responsibility from day one. And don't come here saying, oh, if I had only known. It is your responsibility to take responsibility and do the research that you need to do. You know that once your loved one goes to LTAC, it's often too late. Talking to someone yesterday, their loved one went from ICU to LTAC with trach and PEG, and the day after, they bounced back into ICU, into another ICU, in another hospital. I hear these stories weekly. I don't know how many more times I need to say, do not go to LTAC, and we can help you keeping your loved one in LTAC. We've done it. We can help you keep your loved one in ICU. We've done it many times. Proven strategies for our US audience. And if you want to go at home, if you're in the US, reach out to Intensive Care at Home. We can help you with ICU nurses in the US privately. Right? But stop complaining and take responsibility. Take responsibility. Okay, so let's move on to Dare 56 had a couple of more comments here saying also something I just remembered. My mother the last 2 days begun to cry, and also she's sweating a lot even if her temperature is good. We have no information from the doctors. She's taking meds for epilepsy, painkillers, fentanyl, and blood clot thrombosis. So Dare 56, if she has a temperature, no, if she doesn't have a temperature, but she's sweating, look, that could be part of the brain injury, that she can't control and regulate her temperature. That's what I would think it is, or what I think it might be, right? She might simply be sweating from the brain injury. She might also be sweating, might be too warm in the room she's in. You know, maybe she needs a fan, maybe she needs a cold wash. You know, common sense. Once again, it all comes down to common sense, right? Also, why is she taking medications for epilepsy? Is she at risk of seizures? Does she have seizures? Right? Fentanyl, why is she taking fentanyl? Is she in pain? And if she's in pain, why is she in pain? Is that something that can be sorted without the fentanyl? And as long as she's immobile, she probably needs anticoagulation for the prevent blood clots and thrombosis. She probably needs something, unless she's wearing TET stockings. Okay, so let's move on to the next question. Please keep typing your questions into the chat pad here. If not, I'll just keep reading out the questions here, or you can join me live on the call by clicking on the StreamYard link, which I have posted in the chat pad, and I will post it again now. We still have some time. Next question from Heather. Hi, Patrik. I have a loved one in ICU. Or before I read that out, Dare 56. Yeah, okay. While she sweats, her derma is really cold. I see. I don't know about the epilepsy because she doesn't have, and also painkillers. Maybe because they broke her ribs while they're regenerated. Right. But if she's got fractured ribs, that would be a while ago. I would hope. That would be a while ago, I would hope. I don't think that that fentanyl is necessary here. The epilepsy had begun while they're trying to wake her up. Okay. So you think that if they take the epilepsy drugs off, she will have seizures? The ribs were 15th of January. That's 2 months ago, Dare 56. She shouldn't need any more fentanyl for... No, fentanyl is no good. It's no good at all. Fentanyl is addictive. Fentanyl has respiratory depression as a side effect. It is no good at all. It should be given for chronic pain patients, you know, patients in palliative care, chronic cancer, patients in an induced coma, but not for your mum, from what I understand. What's happening there with your mum, Dare 56. Fentanyl is definitely no good. Okay. All right. So let's read out the question from Heather, who says, Hi, Patrik. I have a loved one in ICU. My baby brother. And you're saying Dare 56. I don't believe that she should get fentanyl. And well, I'd say definitely not the fentanyl. Epilepsy medications, it really depends. You know, if she is at risk of seizures, it's probably good that she's taking them. So it really depends on what's going on there. You know, she might need them. I don't know. But, you know, again, the questions I believe need to be asked. The questions need to be asked. Okay, so now let's keep reading out the questions here. Hi, Patrick. I have a loved one in ICU. My baby brother was in a coma since the day after Christmas. They had him at another hospital 2 hours away. That hospital was trying to push us to remove his ventilation and let him go. The sub had told us he was unresponsive, wasn't awake often, and that he was brain dead. They said no activity, he wasn't breathing. We didn't want to do so, so we declined the topic. He was moved back to the hospital locally 3 days ago. We went to speak to the care team and he was awake. He was tracking movement with eyes and would look to sounds. Now, with that being said, he wasn't able to respond to commands, but it was his first day awake almost all day. He does jerk his feet away if you touch his toes or try to tickle. He will hold eye contact for short periods and then wander off from it. I believe he has tried to acknowledge the statement once, but I'm not sure if it was just good timing for a weird ooh something sounding horn to a very impactful statement from his oldest son. Also, we put his stepmom on the phone for him to hear her again. I'm not sure if it was another perfect time, not if a weird neurological response, but he had a face of upset and wanted to cry. Then a single tear rolled down one cheek. When I went to wipe said tear, he reacted with his eyes as if he knew I was moving my hand near. He responds to touch, rubbing off the head and belly. Like a baby does, his eyes roll like it feels good. So I'm not sure what is what. He overdosed and was laying there a long time. He does have brain damage from lack of oxygen, unknown time. I'm just looking for answers and hope so we can make the right choices for him. Thank you for all your helpful information, from Heather. Okay. Right. First thing is, there are many clients we work with that are telling us that, the ICU team says their loved one is brain dead. Well, two things here. A, there need to be two independent doctors doing brain death testing. Right? They need to be completely independent from each other. That's number one. And number two, you need to give consent. Many jurisdictions where they need to ask you for consent. So in this situation, clearly the man is not brain dead because he's already responding. Makes you wonder, is their clinical judgment potentially flawed? Right? What's the agenda of testing someone for brain dead? Right? So obviously he's now waking up, right? Again, how long is a piece of string for him to wake up? I don't know. Every day you're not doing something. Every day you're not waking him up. Every day, you're not mobilizing him. Every day you're not moving things forward is a waste of time, right? And look, you're talking about he had a face of upset and wanted to cry, then a single tear rolled down one cheek. When I went rubbing off the head, when I went to wipe said tear, he reacted with his eyes as if he knew I was moving my hand. Yeah. Well, he's probably recognizing you, and that's a good thing. That's a good thing. So the answer really is, well, the good thing is he's not brain dead. The good thing is his brain is working, right? So similar to Leo earlier, get rehabilitation going, get him mobilized. You haven't shared whether he's ventilated, he's got a tracheostomy, you haven't shared any of that. But one way or another, even if he does, let's just say worst case scenario, he's ventilated, he's got a tracheostomy, he needs to get mobilized. And if he doesn't have a ventilator and a tracheostomy, he needs to get mobilized. You need to move things forward. You need to move things forward. Go with your gut. If you had given up, you would have told them to give up. But the reason that you're writing in is you haven't given up. And your brother hasn't given up. Your brother is still here. There's a reason for that. There would also be a reason for it if he wasn't here anymore. but he's still with you. Isn't that a sign of hope in and of itself? You know, what do you think he wants? Do you think he wants to give up, or do you think he wants to keep going? I can't answer that question for you, but I'm sure you can. Okay, Dare 56. I think fentanyl through a patch in the area of the tracheostomy. Sorry for adding new details every time. I argue the fentanyl patch is probably sitting somewhere below the shoulder, either somewhere below the shoulder or potentially on the back. But the sooner you can get rid of the fentanyl, the better. Right? The sooner you can get off the fentanyl, the better. Okay. I think we are going to wrap this up today because there seems to be no other question. I've done another YouTube live yesterday. You know, because we get so many questions, and beyond the YouTube live, we also have a membership for families of critically ill patients in intensive care at intensivecarehotline.com. If you click on the membership link there, you can get access there, or you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. In the membership, you also have access to 21 ebooks and 21 videos that are specifically designed for families in intensive care that help you with steering the wheel while your loved one is in intensive care. It will help you to make informed decisions, have peace of mind, control, power, and influence, right? Once again, I have worked in intensive care for over 20 years, nearly 25 years in 3 different countries. And I have worked as a nurse manager in ICU. I've been consulting and advocating for families in intensive care since 2013. And once again, we have saved lives as part of our consulting and advocacy. And you can look that up on our testimonial section, and you can look it up on our podcast where we interviewed clients, right? Without any hint of exaggeration, we have saved lives here, right? I also offer one-on-one consulting for families in intensive care over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. I talk to you and your families directly, and I'll give you a real-time crash course in intensive care so that you understand what you need to look for, so that you understand what questions you need to ask, so that you understand how to take responsibility for anything that's coming your way, right? I also talk to doctors and nurses directly. And when I talk to them directly with you, I ask all the questions you haven't even considered asking. But you must ask when you have a loved one in intensive care so that you can make informed decisions. You have peace of mind, control, power, and influence. We also offer medical record reviews in real time so that you can get a second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. I also represent you in family meetings with intensive care teams, right? I make sure that you follow the right strategy. I also make sure that going into a meeting is the right strategy. There are times where going into a meeting with intensive care teams is the wrong strategy, right? Now, also, if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share this video with your friends and families. Leave your comments, what you want to see next, what questions and insights you have, so I can address them in other videos. Like I said, we also offer intensive care at home. At intensivecareathome.com, we provide a genuine alternative to a long-term stay in intensive care. With intensive care at home, we are currently operating all around Australia in all major capital cities, as well as in regional and rural areas. We are an NDIS-approved service provider. We are TAC-approved in Victoria, ICARE in New South Wales, NIISQ in Queensland. We also DVA-approved service provider all around Australia. we are also having received funding through private health funds as well as public hospitals and departments of health. We also provide level 2 and level 3 NDIS specialist support coordination. And we're also currently providing an emergency department bypass service for the Western Sydney local area health district in Sydney. We can do the same for your ICU and for your ED, providing a bypass service, keeping patients at home with CCRNs, especially when it comes to high acuity in the community, ventilation, tracheostomy, home TPN, home IV potassium infusions, BiPAP, CPAP ventilation, tracheostomy care without ventilation, and also home port management, central line management, PICC line management, Hickman's line management. So I'll wrap it up here. And more information about intensive care at home you get at intensivecareathome.com. Please contact us on one of the numbers on the top of our website at intensivecareathome.com. Send us an email to info@intensivecareathome.com. For intensive care hotline, call us on one of the numbers on the top of our website at intensivecarehotline.com or send us an email to support@intensivecarehotline.com. Thank you so much for watching. I will talk to you during the week in my quick tip videos. Take care for now.